Well, good morning, good morning, good morning. What a lovely morning it is. Oh, someone's having a new thatched roof. I've got a barn with a thatched roof. One day I'm going to have to get that sorted out. So, how are you? As you can tell, it's a very lovely sunny day. Puffy white clouds. Not massively warm, we're still only in June, but nice, you know. June is living up to expectations and it's our busiest month of the year. Try and see if I can line that up a bit. It's bad, isn't it? So we're rushed off our feet. Just as soon as I get rid of the receptionist, the phone starts ringing off the hook. Still, I'm going on holiday at the end of the week, so I'll be in Crete for 2 weeks. So I'm just sort of finalising everything, crossing the T's, dotting the I's before I go away. We had a massively busy day yesterday, hygienist in, me, 2 nurses, and yet we still managed to field the phone calls and emails. Most people send in appointment, you know, I mean the only reason people ring is if they've got like an emergency or they're a new patient, you know. I should imagine most other surgeries still do most stuff by telephone, so whereas my lot, once they're on the books, they do everything by email because they know they get like an instant reply, or at least within sort of 12 hours or so. I mean, a lot of them get home and do their emails at 8 or 10 o'clock in the evening. So 2 interesting things happened yesterday. One was I had a chat with my hygienist, which was a bit overdue, but you know, I'm a great believer in discussion at the time. You can't like 6 months later say to someone, oh, by the way, this thing's been bugging me, you've been doing this for a year. You know, you have to tell them at the time. Otherwise you'll forfeit the right to bring it up, really. And this was she has a different treatment philosophy to me. And this can be a problem in practice. Supposing you have 2 dentists who've got completely different treatment philosophies. So for example, supposing you've got one dentist who's very happy using amalgam, thinks it's an excellent material, good track record. All the scare stories about it are grossly exaggerated and mostly unfounded. And it's an excellent material, you know, you can pack it upside down underwater and you still get a really, really good, long-lasting result. And another dentist who's a mercury-free dentist, who spends his entire time telling patients that why take the chance, you know. Mercury is an industrial poison, and why don't you, you shouldn't, and it leaks out of your teeth and you end up swallowing it, etc., etc. I mean, both are, I wouldn't say mainstream, but they're, you know, it would be possible to have 2 dentists with those 2 views. And they would each have their own practices, but the problem would be that, you know, there would be some cross-pollination of ideas, and instead of coming to a clinical compromise, what would happen is that you'd get patients saying that, you know, you've recommended I have a mercury filling, but I know there's a dentist here who says that you should never have a mercury filling. You know, what do I do? How do you reconcile that? And then the other chap would have a guy saying, well, you know, you told me that I shouldn't have a mercury filling because it's, you know, there are very good reasons not to, and yet there's a bloke upstairs who I know for a fact who puts them in routinely. So as a practice, how do you justify that? So you have like a clinical tension there, you know, that it's sort of a chronic tension, but it has to be resolved. And usually it's resolved by one of the dentists leaving the practice and setting up, you know, practices. They need to have some sort of consistent practice philosophy. So if you've got a mercury-free dentist, you tend to have a mercury-free practice. a mercury-free dentist probably wouldn't hire an associate who put a load of amalgam fillings in. So what happens when you've got the similar chronic clinical contradiction and tension between a dentist and a hygienist? And in this case, it's between myself as a dentist, who's very much a ends-based clinician, and the hygienist, who, through no fault of her own, has been trained in a very much a means-based approach, as has every hygienist. She's in claiming that she's the mainstream and I'm the outlier. She's quite correct. She is certainly part of her routine is to ask the patients how many times a day they brush, whether they floss, and to recommend and show them on the model how to brush, and to sort of load them up with all sorts of the modern accoutrements, of modern dental hygiene, such as TP brushes, who, for some reason it's become the received wisdom that everyone needs to stuff TP brushes in between their teeth. TP brushes, they're the new floss, the new thing that probably causes more damage than good, and yet is recommended by almost every hygienist, much to the benefit of the shareholders of a TP corporation, no doubt. So, my approach is very much, and it is founded, I have to say, on 35 years of experience doing this all day, every day, is to explain what the problem is to the patient. The problem is not that they don't brush properly. The problem is that plaque grows on their teeth. And the solution to that problem is to remove the plaque. Now then, you can then enter into discussion about what's the cheapest and quickest and most effective way of doing that. But just because that's the end point of the discussion doesn't mean that you can save time by making it the start point of any discussion. How many people are brushing who don't actually know, other than what, it's like the 11th commandment, one should brush one's teeth. How many people are brushing without any idea of the sort of the fundamental tenets behind that recommendation? So I start off with saying that bacteria grow naturally in the mouth and they irritate the gums, makes the gums shrink over a period of time. Your teeth get loose and fall out. The way you prevent that is to reduce, so far as possible, the number of bacteria in your mouth, and you do that by literally mechanically brushing them off. But before you can brush them off, you have to see where they are. So you chew up a disclosing tablet from time to time, not every day, but just from time to time. Gives you a good idea how you need to target your brushing. So then we wait and see if they're capable of absorbing that message, and they've got the manual dexterity and the inclination to follow your recommendation to sort of try and become a plaque-free zone. Then, and only then, can you go on, if necessary, to recommend the next stage. So if someone, for example, has got quite large gaps in between their teeth already, because they've already had a bout of advanced gingivitis, or they've got periodontitis, then you might say, well, look, you could speed this whole process up with an interspace brush. Or, but really, very rarely, by the time people are brushing as thoroughly as I want them to brush, the bristles of their brush are going right the way between their teeth anyway. So that really gets the need for TP brushes and floss out the window. And certainly people cling on to electric toothbrushes. In fact, I had a woman in yesterday, or day before yesterday, who said that she was over brushing her teeth, and so because with a manual brush, she was over brushing her teeth, and so the dentist, her previous dentist, had recommended an electric brush because it might stop her over brushing. Which is a bit like saying you're scrubbing all the skin off your feet with a pumice. Why don't you try a Black & Decker? I honestly don't understand. That qualified as the worst bit of dental advice of the year so far. So trying to get people to tread the fine line between underbrushing and overbrushing so much that they damage their teeth and gums is the name of the game. Now, why is this hygienist so inconsistent? Well, because I am saying to people, and we get a lot of people who come in and say, I've been to the dentist every 6 months, I always do everything they tell me, I can't understand why I keep getting told off, and now you're telling me I'm still not brushing properly. I don't know what else, I've given up, I don't know what else I can do, I can't do any more, just don't even talk to me, I'm fed up with a lot of you. And so my attitude there is to say, well look, just drop it all and start again, go back to basics. Gum disease, plaque, disclosing tablets, 30p brush, see how we get on with that, throw everything else out the window. Now, then they are then going to see the hygienist, who is then saying, do you do this? If you don't do this, then do it. If you do this. If you don't do this, then you should do it. This exact sort of prescriptive means-based approach, where if you do what the hygienist says, then everything will be fine, and it's not fine. This is what I was trying to explain to her yesterday. Nobody really ever saved their teeth by being shown how to brush on a model, which is why I do it in the mouth. But I'm sad to say the outcome of the discussion was not brilliant. By which not brilliant, I mean pretty dismal. Which is that she pretty well told me that she didn't understand what I was saying. She didn't think there was any difference between what I was telling the patients and what she was telling the patients, and in any way, to the extent that there was. She was getting an improvement in their oral health, and therefore this improvement justified the approach, and finished off by telling me that she thought I was having a bad day, and I just decided to pick on her. And when I said to her, it's a private practice, do you think you could be a little bit more, for want of a better word, private with the patients? She was like, she said, I'm not these patients' friend. And she said this. I'm not these patients' friend. I am not there to talk to them about. And she said, I will make a note of, if their father's died or something, and so I just got some notes, But I'm not there to socialise with them or chat with them at all. I'm there to be their hygienist and do some hygiening, And I don't have enough time to socialise. Bearing in mind she's seeing 2 patients an hour, and she's got a nurse to do all her cleaning up and everything. So pretty well, it's difficult, isn't it, in an age where we're encouraged to be sort of reflective about our clinical positions, and we welcome third-party opinions, or second-party opinions. We should, if someone, I love feedback, good and bad, especially bad. It's very difficult to get bad feedback, I find. We send every patient a questionnaire at the end of their treatment, and we ask them to rate us on a scale of 1 to 5, where 1 is terrible and 5 is pretty well, couldn't be any better. And to give us a suggestion. There's a little thing underneath. It just says rates us 1 to 5. Anything we could have done better, or anything we could have, anything went wrong, or anything. And we've had about 100 of these things back, and I think all bar 1 are 5. And the only one that wasn't a 5 was a bloke who put a 1 as a joke and said, yeah, that's right. I would, I'm likely to go and see a dentist who's useless, aren't I? So. And if they write anything at all in the line, it's just like, oh, Derek is a brilliant dentist. Derek is I recommend anyone to go and see them, which is good. And I'm not saying this to blow my own trumpet, or because we don't appreciate that, or because we can't use those comments in our advertising, because we can. This is all useful. But I'd far rather someone write in and say, Derek has in his waiting room the Telegraph and the Guardian, and I would far rather he had the Sun and the Daily Mirror. That would be useful feedback. Do you know what I mean? That would be, like, oh, okay, then let's have a think about that. But the sort of the negative feedback we get is, this woman who made an appointment the other day at short notice, and then when we rang her up, said she forgot, and then when we asked her if she could come in, she said no, she couldn't come in because actually she hadn't forgot, she was ill and and had 2 panic attacks already. So what on earth were we playing at, asking her to come in? And so then we sent her a bill for wasting our time, which she then sent back with a rude comment. I mean, that's the sort of closest we get to a complaint that she can't do exactly what she wants. So what do you do? I mean, she's obviously not very introspective. She's not, I would have appreciated it if she'd said to me, okay, no, I hear what you're saying, and I will go away and think about it and come back to you with a considered response, because all I was asking was that we just try and close this clinical gap between us. So this I wouldn't call it a gulf, but I mean, everybody starts off where she is now. Everybody starts off there. In the same way as when you're a boss, you start off with you all start off with this autocratic management style where everybody has to run every decision past you, and you have to decide how everything's done, and so you end up with a bunch of staff that are, broadly speaking, pretty unhappy, and you end up with a more teleocratic style of management whereby you've got experienced staff. They know exactly, they can second guess what you would do under the circumstances, and so your workload drops dramatically, and you have a much happier, more empowered bunch of staff and the surgery runs better as a result. So you go in the same way as you go from autocratic to teleocratic. As a clinician, you tend to go more from, it's not about the drilling and the technical side. It's all about the end result. So what are you trying to achieve? Where is the patient trying to get? And I've had patients come in who could have had 4 postcrowns, who've ended up going away with a denture, immediate replacement for all their front teeth, because that is what makes them deliriously happy. That is what they want, and it was a clinically supportable treatment plan. So don't it's all about benefits, isn't it, not features. And she's stuck in the way that everyone's trained, but she's also not very capable of taking criticism, which is how she sees it. She's very defensive and in denial about certain aspects, and felt like she was being called to, instead of 2 colleagues having a chat, she felt like she was being called to the headmaster's office for ticking off. And I don't know how you cope with it. I mean, if you're in my stage of the career, which has sort of been working 25, 30, 35 years, and you're talking to someone who's perhaps been qualified less than 5 years or something, how do you talk to them on a one-to-one basis, without it appearing that you saying, oh, well, I'm telling you this because I've been in the job 35 years and I know that this works. You should just save some time and just do things the old-fashioned way, which is how they see it. They see, I suppose, practitioners like us as dinosaurs who are trying to make sure that things still get done how they were done in the 1980s. Whereas in fact we are all, for the most part, actually quite benevolent bestowers of advice that will save them a tremendous amount of time and money over the course of their career. But you can lead a horse to water, but you can't make it drink. She can't, if she is going to see this as me criticising her, and in particular sort of trying to influence what she does from a clinical point of view. She's saying, you know, you're just trying to tell me to treat the patients in the same way as you treat them. And I said, no, I'm not. No, I'm not. It seemed to me that she was almost like she was confused, because she wasn't sure whether that's what I was trying to tell her to do, or whether that's what I wasn't. Because in a way, I think she almost would have welcomed it if I had said to her, well, while you're working here, I want you to do things this way. I think she would have then, because then she would have, in her own head, she would have been able to have thought, well, this is the practice where the principal's a bit weird and he expects me to do things a certain way. And I'm sure she does adapt from surgery to surgery, but the problem is that we're the only private surgery she works in. And so the rest of the week she's at a variety of NHS surgeries where, to be honest with you, the principal doesn't even care what she does, you know, and certainly doesn't disclose the patients, and certainly doesn't discuss oral hygiene with the patient, and certainly doesn't show the patients how to brush. I mean, that is the hygienist's job, isn't it, in most surgeries? Then the principal doesn't really take much interest in the periodontal health of the patients. He's more interested in doing implants and advanced crown and bridge work and stuff like that. So we'll have to see how it works out. I mean, you know, I don't want to tell her how to do things. What I want her to do is I want her to think for herself and come back to me with a considered reply and some proposals about how we can close this gap of clinical opinion. Because it's not, you know what they say, if you don't agree, or someone doesn't agree with you, then you need to find out why, because one of you is probably wrong. And I'd like to find out if it's me that's wrong. But I don't, like, with the confidence that comes with youth, she's absolutely certain that it's not her that's wrong. So I don't know where we're going with it, you know. We'll have to see if she changes her approach at all. But one thing for certain is I cannot have a situation where I'm saying to patients, look, use the disclosing tablets, use a brush, and then they are then stepping out. They're literally walking across. They're walking 3 yards to the hygienist surgery, and she is then saying to them, right, how are you brushing? How many times a day do you brush? Do you use TP brushes? Do you floss? How many times a day do you floss? Etc. 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 And that's just too much of a clinical tension there, you know, because the patients are then, and also, you know, there's a certain, she's very clinical. And imagine you went to your hairdresser and sat down and, you know, looking forward to having your hair cut, and then the hairdresser said, well, look, before I pick up my scissors, I just want to go through with you, I want you to tell me what shampoo you use, and how many times a week do you wash your hair, and do you do it in the morning and the afternoon, and what type of, do you curl your hair, you know, have you got tongs, what temperature are the tongs, how often do you do that, you know. And the patient and the patients immediately like switch off. They, do you floss? Do you floss? Yes, I floss. I mean, they know, they're given the answer. Do you floss? Yes, I floss. Okay. Of course they don't. I think she believes they do. The way to find out is to go to a drawer, tear off a couple of feet of floss, and say, okay, let's see how you're doing it. See if we can improve. And then they'll look at it. You know, they'll look at it like those programs where the people are going through customs, and they got a 200 weight of rolling tobacco, and the customs officer says to them, "Is this for your personal use?" They, "Oh yeah, it's for my personal use." So the customs officer says, "Right here, here's a Rizzler. Just roll one up for me, just to show me how you can do it." And they look, and they're like, well, it's obviously not for their personal use, because these guys have never smoked, never rolled up a fag in their life, you know. And it's the same with the floss. You do floss. Oh yeah. Oh, here's a bit of floss then. Show us what you're doing. And of course, it doesn't work like that. You know, they're like, okay, all right, okay. If you're having trouble recognising floss, then perhaps better if you don't floss. Okay, that's this morning's rant. It's an interesting subject, so if anyone's got any feedback on it, then get in touch. Otherwise, I'm off on holiday, so I might do something from holiday. If not, I'll see you in a couple of weeks. Bye.